What are Brighton Collaboration companion guides? Guides are developed to support and supplement a Brighton Collaboration case definition. The purpose of both guide and case definition is to facilitate a standard approach to vaccine safety. Brighton Collaboration case definitions are intended to be used by those who study, report, or evaluate vaccine safety during the entire vaccine lifespan, from pre-authorization clinical trials to post-marketing studies, as well as pharmacovigilance activities. The companion guide offers resources to support users in the understanding, identification, and surveillance of specific adverse events, as well as tools to guide the application of the case definition in terms of gathering relevant information and assessing the level of diagnostic certainty. So what does the companion guide include? The guides are composed of 5 sections that provide different resources and tools related to the specific adverse event. We will look at each in turn and provide examples from existing guides to show how the content can be applied. Section 1 provides medical codes for the adverse event. The codes and terms relate to the diagnosis of the specific event of interest, as opposed to individual signs and symptoms that may be present. ICD-9 and ICD-10 codes are generated by WHO and used by healthcare systems to code medical histories and healthcare events in electronic healthcare records. SNOMED codes are developed for the same purpose by the International Health Terminology Standards Development Organization. MEDRA stands for the Medical Dictionary for Regulatory Activities. MEDRA was created and is maintained by MSSO. MEDRA is used by regulatory authorities and industry to code for several different types of information, including medical, family or social history, symptoms, physical exam findings, lab test results, as well as specific disease diagnoses. The companion guide focuses on providing MEDRA codes for the last category, specific disease diagnoses. In contrast, MSSO creates standardized MEDRA queries, or SMQs for short, which combine terms from many different categories. SMQs are designed to be sensitive and therefore are more suitable for signal detection in pharmacovigilance databases. Here's an example from the companion guide for Bell's palsy. The key information in the table is found in the columns under the diagnostic coding system terms and codes. The different terms are synonyms that are used by some, but not all coding systems. The companion guide always provides codes and terms that are very specific to the event of interest, referred to as narrow search terms. For Bell's palsy, there is only one narrow search term that actually specifies Bell's palsy. The guide may also provide broader search terms which may indicate a diagnosis or possibly symptoms. For Bell's palsy, the broad search terms include things like facial palsy and facial weakness. Bell's palsy would be captured by these, but so would many other entities that don't meet the Bell's palsy case definition, which is restricted to a peripheral facial nerve palsy with no identified cause. So how can this information be used? Here are some examples. The codes and terms listed in the guide can be used in studies to determine the background rates of Bell's palsy in the general population before a vaccine program is started, or to conduct epidemiologic studies on the risk of Bell's palsy following vaccination. Such studies that are often conducted in electronic health records need a code list to be created to identify the events from administrative electronic databases. The companion guide provides the ICD-9-CM, ICD-10-CM, and SNOMED codes that can be incorporated in such a code list to identify the cases in the data sources. Section 2 provides published background incidents. Diseases are often multifactorial, and many events that may be reported after vaccination can also occur without vaccination. Thus, background rates are the incidence rates that would be expected for the event in the absence of vaccination. While an adverse event that occurs after vaccination may have been caused by a vaccine, it is also possible that something else caused it, such as a prior infection, a genetic disorder, or an environmental exposure. In other words, that event would have still occurred even if a vaccine hadn't been given. This is why it is important to know the background incidence of the event in the population before beginning a vaccine trial, study, or program. The example shown here has data on the incidence of a generalized convulsive seizure from a population-based study done in Ethiopia. The companion guide presents a table summarizing the published incidence rate data for the event based on the definition of the event as described by the authors of the publication. It's important to note that the case definition used can differ between publications and often is not based on the Brighton case definition. The information in the table is organized by geographic region and includes information on where and when the data were collected, as well as age groups and sex and other characteristics of the population, if provided in the publication. Most guides have rates from many different geographic locations. Given differences in the populations, methodology, and definitions used in different studies, there is variability and heterogeneity in the published rates. Thus, when possible, it's best to use background incidence rate data generated in the same country or location and population as that being studied. Section 3 presents risk factors for the adverse event. Risk factors are defined as factors that contribute to or cause the specific event. The guide summarizes information in a tabular format as shown here for sensory neural hearing loss. Included are host factors such as age, sex, genetic makeup, or presence of comorbidities. External factors such as trauma, infections, medications, toxins, or vaccines, and behaviors such as lifestyle, diet, travel, occupation, and drug or alcohol use. This table was edited for ease of visual presentation during this video, but a much more detailed one can be found in the guide. So let's look at sensory neural hearing loss as an example of how risk factor data can be used. As shown in the table, SNHL is a known complication of Lassa fever that usually occurs in the convalescent phase of disease. Evidence suggests that it could result from the immune response to the virus. It's therefore theoretically possible that a vaccine against Lassa fever could also cause sensory neural hearing loss. Thus, individuals participating in Lassa fever vaccine trials may be screened and followed for hearing loss. Knowledge of the risk factors for sensory neural hearing loss enables study investigators to design their study to ensure that study groups will be similar in terms of prevalence of these risk factors. Further, if hearing loss is reported following vaccination, the assessment of risk factors can help guide investigation and thus causality assessment of the event. In observational safety cohort studies, risk factors should be assessed at baseline and compared between cohorts as potential confounders or effect modifiers. Section 4 presents key case definition criteria and recommendations for investigations done in real time. Some Brighton Collaboration case definitions are extremely simple. Fever's a good example. It has a single level of diagnostic certainty and only 2 footnotes to the entire definition. Other case definitions are far more complex. For example, Guillain-Barré syndrome, or GBS, has 3 levels of certainty, and there are 39 separate footnotes. While the case definitions are intended to provide a uniform approach for defining adverse events, individual users of the case definition will not necessarily have the same understanding of the definition and may not apply it in a uniform way. The key case definition criteria section of the guide summarizes the most important aspects of the case definition in bullet points rather than footnotes. For GBS, it's noted that the case definition level 3 can be met based on clinical criteria only, but also that to meet any level of certainty, there must be bilateral weakness of arms or legs, and deep tendon reflexes must be absent or decreased in the weak limbs. Another key caveat is that while alternative diagnoses rule GBS out, the case definition doesn't require that testing for other causes be done. It also provides recommendations for investigation of cases that are identified in a clinical trial setting when real-time investigations can be undertaken. The recommendations for data collection and analyses of the adverse event itself, as made by the Case Definition Working Group, are also presented. Section 5 has a data abstraction form for determining case definition level of diagnostic certainty and an algorithm that can be used to assess the level of diagnostic certainty of a given case. This can be used as a tool in a clinical case report form for collecting data to be used in the assessment of a specified ASI, or in the retrospective assessment of the level of diagnostic certainty of a case in a spontaneous reporting database. We'll use thrombocytopenia as an example of how to use the data abstraction form. This case definition has only 3 criteria: platelet count evidence of thrombocytopenia, peripheral blood smear that confirms the low platelet count, and clinical evidence of spontaneous bleeding. The first step in determining the level of diagnostic certainty is to fill in the data collection form as completely as possible. It's important to understand the meaning of the 3 options to answer. Yes means that there was definitive evidence that the criterion was present. For example, a lab result showing that the platelet count at the time of admission to hospital was abnormally low. No means that there was definitive evidence that the criterion was absent. For example, the admitting platelet count was in the normal range, which is usually 150 to 300 times 10 to the 9th per liter. Unknown means that there is uncertainty in interpreting whether or not the criterion was present or absent. For example, no platelet count was done, or if done, no results can be found. Some terms in the data collection form are highlighted to indicate that there is a definition for the term in the glossary, which is presented at the end of the section. For example, epistaxis is the medical term for nosebleed. Here's an example of a completed data collection form for a possible case of thrombocytopenia. In this case, there was a documented platelet count of less than 150. It was unknown if a peripheral blood smear was done, and so B0.1 is checked unknown, and no further data can be entered for B. The patient had a nosebleed, visible blood in the urine, and petechiae on the skin at the time of admission, so C0.1 is checked yes, and check marks are put for items 2, 3, and 11 in Section C. After completing the data collection form, there are 3 additional steps in the process of assigning the level of diagnostic certainty. Step 2 uses the data entered in 1 to further define certain criteria. For this example, based on the data entered for the case example, the final value for criterion B is unknown because B0.1 was unknown. Criterion C is yes, because there were 3 different pieces of evidence of spontaneous bleeding. Step 3 involves summarizing the final value for each criterion from steps 1 and 2, and then step 4 applies the criterion values determined from the first 3 steps to formulae presented in the rows of the table for level of certainty. It's best to start with level 1 to see if the specified criteria are present. In the example, it is clear that level 1 is met because both A and C equal yes. Given level 1 being met, the user can stop at that point, since level 1 is the most specific level of diagnostic certainty. Each companion guide also has an algorithm in the form of a figure that provides a path to each level of certainty based on the values of the case definition criteria. Depending on the user's expertise, it may be possible to use the one-page algorithm alone to determine level of certainty. In the example we have been discussing, it is clear that A equals yes, B equals unknown, and C equals yes, so that the path leads directly to level 1 thrombocytopenia. Of note, the same form included in the companion guide is available online as part of an automated Brighton classification tool. When using the tool, only the step 1 data form needs to be filled in. All other steps are automated, so once the form is completed, a level of certainty is provided by the tool. A separate video is being prepared to show how to use the tool. So to summarize, first, companion guides are designed to supplement the Brighton case definitions and facilitate their application in safety settings throughout the vaccine life cycle in research, regulatory, and pharmacovigilance settings. Second, the guides provide specific codes that may be used to record or retrieve event diagnoses. They don't provide codes for individual signs and symptoms and are thus not sensitive for the purpose of signal detection in pharmacovigilance databases. Thirdly, the guides provide data collection forms specific to each defined adverse event and guide the user through a series of steps to determine the Brighton level of diagnostic certainty. Feedback from users of the companion guides to improve their value and usability is welcomed. SPEAC conducts ongoing assessments of the guides, but also welcomes individual feedback, which can be submitted as shown. All companion guides are readily available for viewing and download at both the SPEAC Safety Portal and the SPEAC community on Zenodo.